Hello, my name is Robbie, and here I'm going to present my health promotion project. An introduction. Introduction to health promotion intervention for smoking reduction. In Australia, smoking is the leading preventable cause of disease and death. Tobacco smoking was estimated to contribute 12% of the disease burden among Australian, AISW 2021. In Aboriginal and Torres Strait Islander people were 2.9 times as likely as compared with non-Indigenous Australian, and also in Indigenous age 18 and over, it was 43% smoking tobacco, tackling Indigenous smoking 2018. The burden of disease from tobacco use was highest in Northern Territory with 2.1%, 2.1 times as compared with rest of the country, and has the highest among Aboriginal smoking prevalence. In Northern Territory, the Aboriginal and Torres Strait Islander of 18 and over smoked highest in East Arnhem with 53% among women and 56% among male. To close the gap between Aboriginal and non-Aboriginal people, there is essential anti-smoking program in this area as well as systematic support is essential for the health promotion program among adolescents. So our aim of this program is to reduce the adolescent smoking rate by 10% at the end of 2026. And our targeted community is all the Aboriginal and Torres Strait Islander living in the East Arnhem of the Northern Territory. So we are approaching our health promotion intervention through school and community to address the anti-smoking program among Aboriginal and Torres Strait Islander people. So these are the interventions that we are going to include, such as access to quit smoking, counseling, peer education. So we developed meaningful content, method, and tools to ensure knowledge and behavior change. The school setting provide an opportunity and a safe environment in presence of full commitment team, including teachers to boost the students. School teachers, counselor, and the trainer from the host community helps the target individual to feel comfortable to accept the strategy that we are going to implement. For the health promotion, we use socio-ecological model. It is more applicable for this intervention because trans-theoretical model ignores the social context in which change occurs, such as socio-economic status and income, and it applies only for the single unhealthy behaviors and does not consider the impact of others confounding health behaviors. Trans-theoretical model does not address the biological, environmental, and social related to change in behavior. Smoking behavior of Aboriginal and Torres Strait Islander people is a complex behavior which is shaped as the result of the historical, cultural, community, family, as well as personal factors. Socio-ecological model illustrate individual, family, organization, community, and societal factor that influence smoking among adolescents. It reflects that smoking in adolescents is affected both positively and negatively at all levels. Change strategy that most effective and likely to be sustained when directed as at multiple levels. So this is the overview of our project management cycle. So for program implementation, as we already discussed before, that we are going to implement our program in school and community. So in both settings, we are organizing the awareness program and quit smoking program, and then media campaign. So in process evaluation, we start our process evaluation from the after 6 months, and then we collect data from individual groups, from other observations, survey, to know the method, material, and message, and to know whether it is going on the right track or not. So we have the certain checklist regarding the funding, staffing, quality of services, uh, and we conduct the meetings. So for the program designing and re-implementation, because of our resources, because of our money, we are not unable to conduct all the programs that we designed before. So here we are going to reduce some of the um, awareness session, because in planning we have the 6 session. Now we are going to reduce to 4, and we focus on social media, then the mass media, so which is quite expensive. So in impact evaluation, we collect different qualitative and quantitative data, and to know how adolescents behavior and increase their motivation after the implementation of the program. And in outcome evaluation, we do the pre-test and post-test, and we also we have a comparison group with similar community without intervention. So we do the comparison group with that community. So this is our 1 year plan. So in 1 year health implementation plan, we start from the 2 school, and we start awareness program first, and then the media campaign in the first 3 months. So in anti-smoking awareness, we educate at school and community with the training session conducted for 6 months using different resources. After providing training for the staff with the involvement of host community for their ownership and empowerment, and then we start our awareness campaign in the school and community. We use brochure, booklet, pamphlets for the demonstration and the role play for awareness. We explain the adverse effect of smoking and benefit of never smoking, and the technique to prevent the smoking among adolescents, because we are explaining the disease that are occurred because of smoking. So, and from the third month, we are conducting the quit smoking as session as well. So in quit smoking, we just with the help of local government fund, which is used to conduct smoking session to those adolescents wanting to quit through effective counseling in different settings, such as in group, face-to-face, one-on-one, and counseling over phone. So we focus on counseling about the adverse effect of smoking, benefit of never smoking, and the technique how to quit. So activities throughout the year, we will collaborate with the quit organization, and to assist with counseling and support with community program as well. And the media campaign from 6 months, and only media campaign will be conducted in the last 3 months. So in media campaign, we use radio, magazines, outdoor advertising, posters, television, access to mobile phone for the promotion of anti-smoking, focusing adolescents such as life after quitting smoking, financial improvement, and disease prevention. So these are the stakeholders at the community, such like host community, counselor, health educators, adolescents. They have the high interest and influence. So yeah, Department of Health also are in our stakeholders. So these are the stakeholders as school, admin, teachers, health educators, psychology counselors, psychology counselor and health educator. They have the high interest and influence for the program. And evaluation, we do process, impact, and output evaluation. So in process evaluation, we start after the 6 month of the program implementation. The objective is to find out that the adolescent smoking control program is on track or not. So we collect the data from interview, observation, and discussion to our participants, team, and the stakeholders. So to address the interests of adolescents, we collect those information from teachers, trainer, community people, counselor, health personnel, NGOs who are directly engaged during the program. Involvement of local people, we will describe in detail that activities being evaluated, including the method of data collection for the findings, which is essential to know the method, material, and the message that we use for smoking control will work or suggest what we not done well. So feedback from the school and community are recorded. All the program is going on track, going on, and for the corrective action. So for the process evaluation, we use the different checklists like adolescents receiving the service from school and in the communities, background about their qualities, funding, staffing, activities of the total session and meeting will conducted to find out the amount of the success that we achieved during the implementation, redesigning and re-implementation of the program. As we discussed earlier, that due to the limitation of our budget and resources, at this stage, we are focusing on social media rather than mass media, because mass media is quite expensive and we are not able to afford at this stage. So the total number of education session is reduced to 4 session, because before we are planning to do the six session, but it was reduced to 4 from reduced to 4 because 6 session require more resources than our available resources, and there is a need for greater reach of the smoking control activities into the remote part of our target area, which is not enough in our activities. So we are focusing 2 extra session at remote part of the targeted area. Impact evaluation. We will record qualitative and quantitative data to know the immediate change produced by the intervention in school and community, with the change in the awareness, knowledge, attitude, and the belief of smoking behaviors. How adolescents behave after anti-smoking program. So we are going to record about increased motivation of quit smoke. We will record data from family, friends, teachers, host community members to know the changes. Outcome evaluation. So for the outcome evaluation, we do the pre-test assessment and comparison group. So in pre-test assessment, we do pre-test assessment before implementation and post-test assessment after completion to identify whether adolescents change or improve on the outcomes measures. So in comparison group, we will compare with other community of Northern Territory which have not been exposed to intervention to find out the expected outcomes. Outcome evaluation. In outcome evaluation, we evaluate the percentage of our activities such as adolescents who smoke, quit or stay, behavior related to quit, such as call from quit lines and medication use, attitude of adolescents towards smoking, reduction the incidence of smoking. Survey will be conducted after 2 years by the external agency. In conclusion, the result of this health promotion program to reduce the incidence of the smoking among Aboriginal and Torres Strait Islander adolescents with expected outcomes suggested that this program is useful for whole Australia. The achievement in adolescents, Aboriginal and Torres Strait Islander smoking control in our program and its effort to improve the health to close the gap between the Indigenous and non-Indigenous Australian will be helpful in our community as well. Thank you.